And so now, colleagues, if we may, we'll turn to the first of our keynote speakers, Professor Sofia Gruskin, whom I have the great honor of introducing. You all have the biographical notes before you. If I could just say then, firstly, that Sofia Gruskin holds a joint professorial chair as Professor of Preventive Medicine at the University of Southern California, the Keck School of Medicine, and Professor of Preventive Medicine and Law at the University of Southern California Gould School of Law. They're grand titles. They don't begin to capture who Sofia Gruskin is. For anybody who follows the issues of health and human rights, you will be aware that by having Sofia Gruskin with us, we have one of the great architects of the international frameworks for the delivery of healthcare in a manner that's human rights compliant. Some of you will have read the very interesting article in the Irish Times Health Supplement a few days ago, an interview with Sofia Gruskin, and you would have gained a sense of what motivates her, what drives her, and where she came from in this work. And she describes in the interview how it was the inadequate responses to the HIV/AIDS pandemic in the early days of the pandemic that first brought to her attention the need to join the human rights discourse with the discourse of the delivery of healthcare. And it occurred to me, and perhaps she'll speak to it today, she may well have a similar sense with regard to the manner by which so many are engaging with Ebola right now. One gets a sense that very little has been learnt, but that'll be for Professor Gruskin to speak to and not me. But let me leave it there, and let me, with great pleasure and with great gratitude for her willingness to make the exhausting travel from California yesterday, invite Professor Sofia Gruskin to address us.
Brilliant. Good morning, everyone. It is a tremendous pleasure to be here. First to say, President Higgins, your leadership in this area is really an inspiration. I feel extremely grateful for the invitation, and I'm very much honored to be invited to be part of the conversation. And I should say up front that I framed my title as a question, but I want to state clearly I don't see it as a question at all, otherwise I wouldn't be here. All right, so I do strongly believe that the human right to health can inform an ethical approach to improving health and well-being. I thought that what I would do was to start by setting out a roadmap for the time together so you have a sense of where we're going. And my hope is to quickly set the frame for our discussions, then do some bit about defining terms, because I think it's important to be clear why I'm saying what it is that I'm saying, and then spend a bit of time on the right to health and other health-related rights, and briefly touch on the links between ethics and rights as they're relevant to delivering health, because ultimately what I want to be able to do is to propose what a rights-based approach to health can offer, and then offer some few conclusions in going forward. So I want to begin by talking about the conceptual foundations at the link of health and human rights work. In 1994, we set out these three relationships, which to this day remain key to categorizing and thinking about these relationships. And obviously, the ways in which we think about them has expanded quite a bit since that time, but I think that they're still useful as kind of an organizing approach to being able to have this conversation. The first is the impact that health policies and programs can have on human rights, both in terms of promoting rights, but also in terms of violating rights. Think in the context of HIV, then, the difference between voluntary HIV counseling and testing and mandatory HIV testing, just as an example in terms of being able to see how both raise rights issues, but in very different ways. And the second direction, if you like, is the impact that human rights promotion or violation can have on health. Think of the impact of the genocide in Rwanda, not then, but now. Intergenerationally, the longer-term health effects of what have these horrendous human rights violations. Or coming from the United States, think about the former Bush administration had this crazy policy of denying young people access to scientifically accurate sexual education and information with an entire focus on abstinence only. Now, that's something that's going to take an awfully long time for our population to get over. even though it's something that was only in place for a bit of time, but it's something we all need to deal with. And so finally, in terms of the third kind of way of thinking about the linkage, which is really the hypothesis that drives much of the work in this area, which is that health and rights mutually impact on one another, and the best way to maximize health is to maximize rights, and vice versa. So with those as the foundation, let me move a bit to say something about the current context. And in order to do that, I want to begin by giving a just very brief 10-second history. Because even as human rights and public health have been linked for a long time, and there was a lot of work done initially in the women's health movement from all over the world, the first time that human rights were explicitly named in any public health strategy at a global level was in the late 1980s when Jonathan Mann was the director of the Global Program on AIDS at the World Health Organization. The first WHO global response to AIDS called for the human rights of people living with HIV and with AIDS, and for compassion and for solidarity with them. And while this happened partly as a result of the moral outrage we were all feeling about what was happening to people living with HIV in countries around the world, the simple fact was that whether people were interested in human rights or not, the evidence was showing that discrimination against people with HIV was driving people underground. It was creating fertile ground for people not to know their status, not to be tested, and in the language of the time, to further spread the virus. So I'm saying this because the public health motivation for doing this was not because of a concern for human rights, but the implication of this approach being promulgated by the World Health Organization as an intergovernmental organization was far-reaching, because by framing this global health strategy in human rights terms, although it was initially only focused on the human rights of people living with HIV and not on other areas related to health and well-being, anchored it in international law. And it therefore brought attention to the fact that governments and intergovernmental organizations were publicly accountable for their actions towards people in the context of health. So fast forwarding now to the future, the good thing is, as opposed to when we started doing this work, the question is no longer, why are you doing this? Why are you linking health and rights? But how do you actually do it? What does it actually mean to do this in practice? And it's great to be able to stand here and to be able to say that at this point in time, in every region of the world, there is work that is happening which is called health and human rights, mostly in the areas of HIV and sexual and reproductive health and health systems, but increasingly in other areas as well, as people are understanding how it is to bring these concepts together. But the picture's not all that perfect, and I want to put that on the table as well. So even as the human rights community is increasingly engaging in health, there has been a backlash by a number of prominent figures in the global public health community who find human rights to get in the way of what it is that they want to do. Calling human rights, therefore, a target, whether it's political or otherwise, I have a lot of reasons why I can give why I think this is happening, but I want to make sure that it's clear that there are some real issues to deal with, whatever it is for the political motivations that go with this. There are some real issues we need to deal with in terms of why it is that this negativity has started to permeate the conversation. And I think there's a few reasons. I think one issue has been that there has been a real disconnect between what some organizations who say they're doing work which links rights to health do. What they say and what they do are not necessarily quite the same thing. But I think most importantly that doing this work is new, and moving beyond the rhetoric to show what systematic attention to bringing these concepts together can actually do to improve health outcomes is even newer. We're really at the early stages of putting together the evidence base of what it means to do this work and what its positive impacts can be. And that does motivate a lot of my own work, I must say. So let me do some definitions quite quickly, just so it's clear what it is that I'm talking about when I use terms. I'm always on other people that if they say words, that I want to know what it is they mean by those words, so I'm holding myself to account to do the same thing. So therefore, I want to just lay a few things out here. So first, in terms of health, and just to say that there's both the aspirational and the instrumental goals in terms of thinking about how we do this. And in health and human rights work, we touch on both of these dimensions. And since I'm here, I was thinking about the link between international health and global health, and I really see the invitation here as an example of global health in terms of the commonality of health issues and the notion of collective partnership and action, and appreciate the invitation in that sense as part of a framework of global health. But we also all deal then with health as a right, as the right to the enjoyment of the highest attainable standard of physical and mental health. And we engage with health in that way. And I would say that Ireland is joined by 162 other countries that have ratified the Covenant on Economic, Social, and Cultural Rights, which recognize health as a right, but not by my country, not yet. Okay, just to put that out there as well. All right. So in terms of human rights, just generally, I just want to be clear what I mean, because I think that many, many institutions these days use the language of human rights and use it in very different ways. I think it's the blessing or the curse of the language of rights is that everybody feels that they can own it and that they can use it as they like. I think for those of us who work in public health, much more, this happens much more than it happens in clinical medicine or in epidemiology or in statistics or economics or other disciplines concerned with health. But rights is a language that is powerful, so I think it's important that we're clear for ourselves which framework, which definitions are we using in terms of talking about human rights. So I guess my point here really is that the focus I'm using for this part of the presentation is on human rights as they are agreed to by governments. It's not my vision of human rights, but where there's international consensus for what they mean. And of course it means working to advance those definitions, but it's being very aware of what actually does exist and what the limits are, and not just calling something human rights because it's good work or because it's well-intentioned. And that's a point I'm going to want to come back to in just a little bit. Now, at this point in time, every country in the world is party to at least one human rights treaty that has attention to health-related rights, and that means governments in the international community are obligated to promote and protect rights in relationship to health. And these treaties have a focus on a number of different areas. I'm not going to go into them today. Again, I feel responsible as somebody coming from the United States to say we have not taken many of these seriously, and I think it's important for me to put that on the table if I'm speaking in another country in particular, and to be able to say that we, along with South Sudan, remain the only countries in the world that have not ratified the Convention on the Rights of the Child. Okay. But Ireland is in great shape in comparison, may I say. Okay? All right. In terms of political consensus documents, President Higgins was mentioning the Sustainable Development Goals, which is really the direction where things are going in terms of being able to think about how it is that we're looking at the frame of international development. And the point I want to make here is that all of these have commitments, political commitments, that are quite important in terms of bringing rights and health together. Okay. Now, something critical for the health of individuals and populations is that governments are responsible not only for not directly violating rights, but also for ensuring the conditions in which we can realize our rights as fully as possible. And some rights, in fact, can be restricted for public health purposes in some circumstances. I think it goes beyond today's presentation, but the conversation about Ebola raises the fact that I think I should just say that if we're thinking about rights, that there are rights that can be restricted in the name of public health. And yet, a number of criteria need to be addressed if that's in fact to be the case, which is not always the case in how things have happened. All right. Governments are legally responsible for respecting, protecting, and fulfilling rights in these documents. And I think that the thing I want to say in the context of health here is that it's clear that not any government can fulfill all rights immediately and completely, but it's recognized that there's a difference between government incapacity and government unwillingness in terms of working to fulfill those rights. And certainly in the context of health, the question of benchmarks, of targets that are being set, and the notion of showing progressively what a country is doing is extremely important in terms of meeting an obligations and ensuring health for people within a society. The other thing I guess that I should say about that is that there's an obligation for wealthier countries, not only in terms of what they do within their own borders, but also what they do through international assistance and cooperation. So very much to be understood as part of what's done in terms of development assistance, and again, with incredibly important implications for health and well-being. I guess one other point I wanted to make about this, is that I did want to say that the right to health is not the only right that matters. And that one of the things we need to really recognize is that if we truly want to achieve health and well-being, we need to recognize the constellation of rights that are relevant in order for us to be able to fully be healthy and to exist in our societies. It is the right that is most explicitly mentioned, and it is one that I'm going to go into detail, but I would ask you to consider for each one of these rights its implications for health, and to recognize the ways in which they come together, and to think about the implications about looking at them together for actually thinking about rights and health outcomes. Okay. In terms of the right to health, I'm going to start from the health side, and I'm not going to spend a lot of time on this, I promise, but I just want to make sure that it's kind of out there and as the background for what we are talking about. Interestingly, in 1946, we go back to this definition of the right to health from the World Health Organization, which is a pretty good definition, still relevant to us. I mean, personally, the fact that sex and gender are not listed is problematic, but it was 1946, right? But the fact is that I appreciate very much thinking about that as a frame for where we start. But interestingly, as far back as 1970, you have the World Health Organization recognizing that its competence to deal with both the right to health and other human rights in its work. Okay, now from the health side, we start with the glimmer of an understanding of the right to health in the Universal Declaration of Human Rights, and I just want to point here the focus on the underlying determinants of health, the need for a standard of living adequate for health and well-being. And then we move to Article 12 from the Covenant on Economic, Social, and Cultural Rights that was being noted a few times earlier. And again, I want to point out here the focus both on the individual right to the highest attainable standard of health, and what it sets out is the obligations for state parties on the other side, and in particular, the fact that we're looking not only at the delivery of medical services, but in the creation of conditions to ensure not only that the services exist, but that people will use them. Now, while that was set out and all of that makes sense, a specificity in terms of what this means for government obligations was needed. And in 2000, the Committee on Economic, Social, and Cultural Rights came out with General Comment 14. And what matters about this, particularly, is that a lot of these concepts are concepts that resonate with people in public health. These are easy to bring the links together because, if we're thinking about rights-based approaches to health, the need to be able to think about commonalities in language and commonalities in approach are important. And so here, the focus is on the availability, the accessibility, the acceptability, and the quality of health services, what we often call the AAAQ. So that is a piece in terms of the ways of thinking about services, as well as in terms of the underlying determinants of health. And again, I'm not going to read this at all. The only point I wanted to make, I encourage you to read it, and I have bolded out some language in particular that I thought would be of use. The only point I want to make is the last bit, which is the prescription against discrimination. And that's prescription against discrimination in both access to health care and the underlying determinants of health is focused on general grounds of discrimination that we've known about for a long time. But this is the first document that actually talks about discrimination in terms of physical or mental disability, health status, including HIV and AIDS, as well as sexual orientation. And so it's important to recognize that those are prescribed in terms of how it is that we think about discrimination in terms of health more generally. Okay. I'd like to move into a conversation about the links between rights, ethics, and health very quickly. And the only point I want to make here with this slide is just to see how much these resonate with ethical imperatives, how close they are in terms of just their conceptual bit, in terms of being able to think about how these pieces come together. Now, ethics and rights both converge towards the enhancement of health and well-being. Both are based on a sense of fairness and dignity. Both map out the responsibilities of actors engaged in health in relationship to the people they serve. Historically, actually, both stem from the same roots, and within modern history, the world's reactions to the atrocities of the Second World War resulted in the need, in health now, I'm talking about both for ethical guidelines and for human rights law. And so these links between them are quite strong. They converge, they overlap, they complement each other, but some of their differences are also important. I think particularly I want to point out here that while ethics are enriched by a diversity of perspectives and can adapt quickly to evolving issues, there's a nimbleness. Human rights are meant in the first instance to guide the actions of governments, and therefore move quite a bit slower in terms of the development and the evolution in terms of how it is that we can think about there. There's also the difference in terms of human rights being meant in the first instance to guide the actions of governments, whereas ethics are meant in the first instance to guide the actions and relations of individual health researchers, of individual workers. And there's a difference in terms of the question of enforceability. And I think that this rises particularly in terms of the fact that many ethical principles that guide our work are presented as guidelines and as proposed codes of conduct, whereas human rights principles tend to be drafted as international treaties which impose the legal obligations that we've been talking about. Both have health as a strong focus and a concern with physical, mental, and social well-being. And both have a particular focus on the vulnerable, and I would have said marginalized, but I would say perhaps the vulnerable populations that exist in the world, and an awareness of being part of a larger collective interest and a commitment to transparency and to accountability. As my colleague will be talking about ethics and rights in much more detail later, I'm going to leave it there, but I just want to say that there's a number of issues that can be unpacked and explored going forward, but I think are relevant to our ability to be able to think about what difference rights can make for health. Okay. In order to move us, all of this is the prelude to being able to move us into a discussion about what a rights-based approach to health can offer. And I need to then take a step back and say something about approaches to public health generally and how public health decisions are made, because if we're bringing a rights-based approach into public health, we need to see how it's working with or competing against other approaches that exist. The approaches are many and varied, and different practitioners justify their actions based on different ones of these reasons, except for belief. I think there's no one who would actually say that they were making a public health decision building on untested or unproven assumptions. But when I was putting together this slide, there was no way I could not include it, okay? Because certainly it is problematic and certainly a way that certainly some public health decisions are made. But I wanted to lay out here the fact that while ethics and rights may figure into decision-making, this is alongside political, economic, and other considerations in how public health work is done. And so it's important in thinking about the placement of a rights-based approach to think about how all these connect and not thinking about a rights-based approach then in isolation from these other approaches. Okay, now, in terms of how human rights have been used in public health work, I'm really going to focus on the third of these, but I want to distinguish it from the first two. The first is that in health, the language of human rights has been used a lot to draw attention to an issue, to mobilize public opinion, to push for change. For example, in pushing for wider access to HIV treatment. But it hasn't focused on the legal standards. It's about getting attention to an issue. And the fact of whether it's technically correct in a legal sense has not been the most important. Something I have to say as a lawyer was initially difficult for my head to get my head around. I'm there now, but it took me a while to kind of be comfortable with that. okay? But it's an incredibly important part of how of work in health and human rights. The second is in terms of where as a lawyer, I do feel comfortable. It's the use of national courts, and it's the use of the law in a very concrete sort of way. It's this deliberate use of law and legal channels. And I'm not going to focus on that here. I really want to focus on the rights-based approach, but I wanted to distinguish the three to be clear where it is that I'm coming from. So, what do I mean by a rights-based approach? Well, we did a review of all organizations who call their health programming rights-based several years ago. And not surprisingly, we found tremendous diversity between them, as well as actually internally within them. But we devised this diagram to give a visual reminder that if an organization is paying attention to rights concepts, that there are different ways in which this can actually take place. It can be in determining the health issue, it can be design or implementation levels, or it can be in the monitoring and evaluation, or ideally it's in all three. But this obviously has huge differences in how the work is carried out, let alone how it is assessed. But I'd like to say something about each of these concepts because I think they're quite important in terms of how it is that we think about application of a rights-based approach. The first is ensuring attention to the broader legal and policy context within which the program is taking place. And I don't just mean specific regulations concerning the provision of health services, but for example, knowing if there are broader laws and policies that are going to impact on the services that are available to vulnerable population, even if the services are made available. For example, for people who might be illegally within a country or who don't speak the dominant language, or when mandatory reporting is required of people who are known drug users or known sex workers to the authorities. All of these are broader legal implications which are going to have an implication for the uptake of services even if they're available. Then to think about the attention of the participation of affected communities in determining what program should be in place and how communities feel about the program once it is in place and what opportunities there are for them to give feedback about how it is that it's being implemented. Clearly non-discrimination in how the policy and program are carried out, attention to the AAAQ that I've noted before, and transparency in how priorities are set and decisions are made, and accountability for how the project was done and what follows. Okay, but what does that mean? Well, in practical terms, it means that the people that are involved in trying to do this work have to have generally an agreement that they're interested in improving the human rights quality and improving the public health quality of the intervention and what it is that they're doing together. That they're working together and that they're geared towards reaching an outcome which is equally valid in both public health terms and human rights terms. And I think the key point I want to emphasize here is it means you need to bring different disciplines together. No one discipline alone is going to be able to do this. It means bringing different kinds of approaches together. And ultimately, it's really about how we do things. One can almost summarize a rights-based approach to health in terms of being able to say you need to be analyzing and addressing the inequities regarding access and use of services, the laws and policies under which they operate, making sure that the plans, policies, programs, and systems are anchored in a system of rights, and again, paying attention to this kind of grouping of rights as they're relevant here, and a commitment to empowering individuals, especially those most at the margins, to participate in policy formulation and hold accountable those who have a duty to act, and mechanisms of accountability which needs to be in place. Now, the thing is that what human rights does is it forces concrete questions about the factors that figure into the processes that we are all engaged in. It leads to questions about who represents who decides, who do these decisions impact, and in what ways? Who's making the decisions that value one intervention over another, and in what ways are these decisions being made? Explicit application of human rights norms and standards may change the interventions, but they're also likely to change the processes by which decisions are made. And this has implications for what's done or not done, And it also, I have to say, has implications for people who are not sensitive to rights or who say they are allergic to rights. Because there are people who think that adding rights into this equation might be a hindrance. And so it's quite important to be able to be clear about how it is that rights can actually be of added value to being able to do public health work. So let me try to show you what I mean here. Is that if we would all agree that a rights orientation to health means looking beyond the successful achievement of a particular health outcome, such as increasing the proportion of institutional deliveries or lowering fertility levels. Beyond that, we need to be thinking not only about what health services are provided, but how are they provided, specifically what rights principles are in action, and ascertaining whether in addition to the outcome, let's say lowering fertility levels, the how in big. It's about the pathways and the processes to achieve the outcome. For example, does it explicitly ensure that the processes are respectful of rights, or does it violate rights, or does it look to promoting equality more generally? And it brings attention to accountability mechanisms. But there's a range of questions that need to be considered in thinking about what it's going to look like if it is rights-based. And basically, a way to ask the question is, does applying a rights perspective mean that an overarching objective in the provision of services is not only to improve specific health outcomes, but to actually enhance and contribute to health and well-being, as well as the enjoyment of human rights? Or does that go too far? So to be clear, one question that needs to be on the table is whether there is an explicit attention to internationally recognized rights, and if so, what does that mean? Or are rights, or a specific right, more implicitly part of what's being done? Is the program about application of internationally recognized rights, or is it more, let's call it rights infused, meaning that it's harder to pick out the specific right or rights at play in terms of what it is that's being done? This difference between what is explicit and what is implicit has implications for what's done, and it has implications for legal accountability. Just take participation. If it's explicit, you have the right, you know how you can program directly for it, you can measure that it's happening, you can see if programs are meaningfully engaging people. But if it's implicit, it's not so clear what it is that you actually need to be able to look at. So it can still be super effective programming, but the extent to which rights are actually driving the program and can justifiably be seen as part of what is done is actually quite different. And this is where bringing lawyers and public health people together is so important. For lawyers, generally, when the language of rights is invoked, it's very clear. It has to be explicit. Rights have to be grounded in law. So even if those who don't like rights, the fact is people can't say this is just fluff and nonsense because you're able to point to the law and say that it's there. But the fact is that there are very many different ways to be able to think about how rights apply and are used in terms of being able to do public health work. So my point in raising this, is when working with different institutions, with different people, we have to be clear about these differences and how we're talking about rights in health. And again, I want to emphasize, I'm not proposing one over another, but I'm particularly wanting to be clear that there are these differences, and we have to be clear about these differences when we talk to one another and try to do this work. So, in order to be able to start to do a rights-based approach, one of the things we need to do is to look at what we already have in place, what's already in place, and make a decision from a rights perspective to see if it can be improved. And there's a fairly systematic way to be able to think about this in terms of how these issues can come together. For example, you first obviously have to determine the health outcome you're looking at. Is it obesity? Is it HIV? Because it's not all of public health all at once. It's a particular focus as a start, and then it's about taking it from there. And this obviously has implications for the range of the laws, policies, and programs you look at. And again, I want to emphasize that it matters because it matters for which of the laws that you're going to be looking at, which are those that are going to have the most effect in terms of deterring people's access or being able to support people's access. And there's a focus on people's lived experience. And I want to spend a moment here on people. the human face of all of this, because a human rights lens brings people into the light so that we aren't simply talking about services in the abstract, but about the people who need them and use them, and those who need them but don't have them. And all people need access to health services, no matter how empowered or how discriminated against. And it's important in terms of health that we pay attention to the needs and rights of people who are on the margins, whether their behaviors are criminalized because they're engaged in sex work or drug use or illegally within a country, or because they're living with HIV, or because they're transgender, or because they're intersex, or because they're refugees, or because they're internally displaced, or because they're living with disabilities, or because they're from religious or ethnic minorities, or if they fall into one, some, or all of these population groups together. We need to make sure that people are not treated separately, but that all these issues are thought about together. We have to ensure that all people in all of our diversity are able to access the information and the services that we need. Okay, that was my little bit about populations. Sorry about that. Okay. The other thing just to say here then is that a focus on rights means that we need to be absolutely clear the ways in which we're using rights, the approach that's being used to rights, and we need to think about the indicators that are being used to monitor program effectiveness to see if they're good on rights. And I just want to say a word here about indicators. So if you'll excuse my way of saying this, indicators are really the tail that wags the dog in public health. Now, as a dog owner, I know what I mean by this. I don't know if non-dog owners, if this is as familiar to you in terms of what I mean by this. But basically, indicators drive programming. So if we want to ensure that indicators that are used to measure the performance of services take these issues into account, then they have to be rights-based. So this means even in places where performance-based financing is something that's put into place, there has to be a system in place to ensure that human rights are protected. But what do indicators that pay attention to rights look like? Even in programs that are ostensibly rights-based, the reality is that existing quantitative indicators are largely insufficient in terms of how they're conceptualized to bring to light rights concerns. This is true even in how we conceptualize disaggregation of data. And this needs work. How do we ensure disaggregation is statistically valid and yet highlights those who are most discriminated against and most in need of services, and not just because of urban and rural differences? How are we going to improve the dearth of qualitative measures that exist to get at rights issues and policy indicators? How we get at the links between the larger legal and policy environment, which can significantly impact people's access to needed services and make the associations credibly with the health outcomes? All of these are key and need to be better developed. And this is an incredibly important place in terms of where the work is now. So we need to do a better job of generating the evidence, and we therefore need a better job of actually thinking about what these indicators are going to look like, and not just because it's the right thing to do or because of the legal obligation, but because it can truly impact the delivery, uptake, and use of services. Okay, moving forward. Now, the first thing I'd like to say is that different people have different roles in implementing rights-based approaches to health. We have just as much of a need for the organizations that are naming and shaming and calling out violations of rights as we do for people who are actually trying to put those programs in place. So, and I would also say, for people who are trying to demonstrate the value of those rights-based approaches. My plea here is simply for attention to the different roles and the complementarity of trying to do this work, and how it is that we have to understand, again, the differences in how it is that we work in these areas. I guess the other point I wanted to make about this is that these differences have implications not only for how we hear each other, but they have differences for programming, for data collection, as well as for accountability and for legal claims. Okay. I am not going to say a lot about politics. I think President Higgins said it beautifully. So I feel comfortable letting that be. But both big P and small p politics are critical to this conversation. There's no way we can talk about rights-based approaches without thinking about politics and how they come in to play. I do want to focus, though, on capacity. And I want to start with current capacity. I think that a potential deterrent to progress in offering rights-based services is that even those people who care and care deeply about doing rights-based work, many don't have the needed training and therefore don't have the requisite knowledge and skills to truly implement rights-based frameworks. And that is a current concern. That said, my biggest concern is not about what's happening now, but about the next generation. It's about the next generation of researchers, of implementers, of policymakers, of programmers. Education and training is core to where the health and human rights field will be in 10 years and going forward. And things are not in good shape. And I realize I'm an academic, so I'm not unbiased. I have a particular point of view. It's where I work. But consider this an evidence-informed opinion, at least. There are many good training materials and other things that are in place. In fact, some are absolutely excellent. But as a whole, they're entirely inadequate to prepare the next generation of students and of practitioners in every region, or in actuality in any region, to do rights-oriented health work on a range of topics in the next decade and beyond. And most worrisome is that across the globe, funding for doctoral students, for postgraduate work in ethics and in rights, in health, is at an all-time low. And technocratic approaches to health, and I'm using the term advisedly, are increasingly what is being supported. Education, training informed by evidence is critical, and I strongly believe going forward we need a strategy to ensure attention not only to the clinical and technical aspects of health, but also explicit attention to human rights and to the legal, political, economic, social, and cultural issues that are at the foundation of who needs the services and who cannot get them and what's done about it. So there's a dire need to begin a dialogue on lessons to be learned applicable across disciplines, institutions, and continents to support research, teaching, and training going forward in terms of being able to do this work. Okay. My last slide. Since 1994, we have moved from saying that human rights matter for health to actually being able to show how human rights matter for health. But we still have a long way to go. There's a lot of theoretical work that's needed and a lot of empirical work that's needed. Much more theoretical work is needed as to how human rights can best be used alongside other frameworks commonly used in public health, certainly ethics and social justice and epidemiology, but very much economics as well, as very much as a place where we really need to understand how we bring these together. And on the empirical side, we really need to be thinking much more about the differences for different health issues, for example, non-communicable disease, and affected populations, for example, migrants, how it is that this influences the content and the processes of how it is that we do this work. All of this needs to be done, and like I said at the beginning, the field is still young. I mean, on the good side, I guess, working to further these links between human rights and health has meant that new resources have come into play and also new actors. And each of us brings to the table not only a common concern for better health, but our own disciplines. And this can be challenging, particularly as the boundaries between disciplines, countries, and people become increasingly blurred. Nonetheless, I think this coming together of communities, public health workers, including educators, clinicians, ethicists, economists, and human rights workers, lawyers, activists, all of us concerned with health, has the potential to offer an immense contribution to improving physical, mental, and social well-being. But for our work to be useful and to be relevant, there has to be a consistent exchange between those of us doing the conceptual, the empirical, and the policy work, between those who are living these realities on the ground. Bringing explicit attention to ethical principles and human rights will not only strengthen our collective understanding, but more importantly, and I think this is what brings us here today, it will strengthen our collective endeavor to improve health and to realizing the human right to health for everyone. Thank you.
Professor Gruskin, thank you very much indeed. Colleagues, there'll be an opportunity to engage in Q&A with Professor Gruskin after the panel, which will take place just following the coffee break. Professor Gruskin will join the panel for that purpose. So now we have a 30-minute interval, and we invite you to take coffee in the foyer. Thank you.